To NOSM COVID-19 clinical rounds. I'm James Gertson, a family physician and Associate Dean of CPD. I'm hosting today's rounds from Thunder Bay, and I'd like to welcome everyone from across Northern Ontario. Throughout our presentation today, you can forward questions to our presenter through WebEx chat. Just a reminder to everyone, please mute your audio and please turn off your videos in terms of you sending your video, and that way you'll get better images. And I'd like to briefly just introduce you to the COVID-19 round site, which will give you lots of information today and in the future. As you can see on the round site, the evaluation for today is posted, and following the presentation, you can complete the evaluation, leave your name and email, and we will ensure that you receive study credits for attending. On the rounds website, the presentation archives, and you'll notice that you can access Dr. Sandre's slide set, which will be available. And finally, on our clinical resources website, which is a link to the two rounds, you'll notice we have the case status for you in Northern Ontario as of 11 o'clock this morning. We have a total of 279 cases in Northern Ontario. As you see, only 20 cases are active. And finally, we continue to have 14 cases across our First Nations communities in Northern Ontario. The rounds today, there's been no commercial sponsorship. And I'd like to now move on and introduce you to Dr. Sarah McIsaac. Sarah is an anesthetist and critical care specialist in Sudbury. Over to you, Sarah, in Sudbury.
Hi, James. Thanks very much. Welcome all NOSM faculty, learners, and guests. We are very excited to be hosting another one of our weekly COVID-19 rounds. I'd just like to say a very special thanks to our CPD department for their support and continuing work to develop these rounds. If you have any feedback or any particular rounds you want to hear about, please let us know. We're happy to oblige. Today, I am thrilled to be introducing to you my colleague, Dr. Roger Sandre. Dr. Sandre is an infectious disease specialist here at Health Sciences North in Sudbury. And he also holds a ton of titles. He's our medical director of the infection control program and the regional HIV program for the Northeastern Ontario. I get to work really closely with Roger as he's our medical director of antimicrobial stewardship program at HSN, and he keeps me in line and makes sure that I'm not ordering inappropriate antibiotics in the ICU. He's also involved with several trials on HIV, clinical trials in Canada. So we're really excited to have Roger here with us today to talk to us about COVID-19. It's been an evolving infectious disease. It was first reported December 31st in China, and then by March 11th, 2020, the WHO had declared it a pandemic. So it's been a rapidly evolving infectious disease process that's clearly affected the way we live and work right now. So thank you very much, Roger, for spending some time with us today, and I'll turn it over to you.
Okay, thank you very much. I'm just going to share my screen. Hopefully that comes up okay. You can see my slides there. Good. Yes, thank you very much, Sarah, for inviting me to speak on COVID-19. This is, of course, a very evolving disease as we are learning more and more about it. And I'm going to go through quite a bit of information, and I may skip some slides too, depending on timing. I want to leave time for questions, and those can be, I think those will be eventually forwarded to Sarah, and then they can be asked through Sarah, and I'll, even during the presentation and certainly halfway through. So first of all, the learning objectives, I'm going to describe, they're listed here. I'm going to describe some of the characteristics of COVID-19 in regards to immunity and protection and the clinical implications and some of the clinical course of the disease. Of course, that's on the background of the epidemiology, and epidemiologists right now are having a heyday with a huge pandemic that's really been unseen in my lifetime like this. And then I'm going to just identify some of the challenges with treatment, mostly. Speak a little bit about vaccination, but I'm not a vaccination expert. That's a whole science in of itself. And I'm going to cover a number of other topics too, including infection control and a few other issues. First of all, I don't have any disclosures or relationships I have done work with Gilead, just to put that up front, with advisory boards in the past. They are the maker of remdesivir, which is one of the drugs used, but I have no ties to remdesivir or any connection there or any financial ties. So I'm going to start with a case vignette, and this was published in the New England Journal of Medicine. It's not my case, though I could have made one. I have one, but I thought it was quite descriptive, and I'm going to come back to it at the end and just go through a few features and tie things together. This was a case presented, a 73-year-old man with hypertension and COPD who calls into the office where you're working, if you're a physician, who has a fever and a dry cough for about 2 days. And it's during this whole COVID pandemic, of course. He notes he has some shortness of breath, which has worsened. His medications include losartan, inhaled glucocorticoids. He lives alone, but he does live in the area where there is endemic COVID. How should he be evaluated? What should you do? As your physician or healthcare worker on the phone with him, how should you direct him? If he has COVID-19 caused by SARS-CoV-2, how should he be treated? So I'll leave that with you to mull over a little bit. I'll come back to it at the very end. Some of the biology of this disease. First of all, coronaviruses are named because of the crown-like structure around their surface, hence the name corona, and they have protein spikes on their surface. Human coronaviruses were first identified in the mid-1960s. There's about 7 of them that infect humans, and there are very common endemic yearly coronaviruses, which cause about 30 to 40% of the common cold. As I said, they have an envelope around them. They've got protein spikes. S proteins are one of the major proteins on the surface, and it's these S proteins actually that bind to the ACE2 receptor on the host cell in the respiratory tract, and that is right there. So the ACE2 receptor, which is also involved in ACE inhibitors and ARBs, drugs used to treat hypertension. So there is some thought that perhaps those drugs may interfere with the pathogenesis of this disease. But SARS, the original SARS of 2002, as well as SARS-CoV-2, bind to ACE2 receptors in the lung. And then it's got a reproductive cycle through the host cell. It's a single-stranded RNA virus. And there are various drugs which have been targeted at various sites to interfere with replication. One of those is, of course, hydroxychloroquine, been given a lot of news. And this drug works at one level of the virus, possibly affecting invasion by the virus. Other drugs like lopinavir, I use in the HIV world. It's a protease inhibitor. There's thought that it may help. I'll talk about this later. And then, of course, there's remdesivir, which is the newest drug, and it works at the RNA polymerase level. So this is all different cycles of its reproduction. There are, of course, other respiratory coronaviruses which cause severe disease. And this, the most famous, of course, being SARS-CoV-1 from China in 2002, 2003, which had a very distinct epidemic right from the beginning, right to its very end, and never appeared again. And then there is MERS-CoV from Saudi Arabia, spread through camels, and it still exists, and its mortality was very high, a mortality of about 34%. And now we have this novel coronavirus. Now, if you look at seasonal coronaviruses and influenza, your usual seasonal variation, it has distinct patterns. And coronaviruses and influenza here in this graph is the large dark curve, and the lower bars are various strains of coronaviruses, and they peak in the winter months every year and more or less disappear in the summer. Will this happen with COVID-19? We don't know, but there's no reason to think that it won't. The virus is now endemic. It's now entrenched in the population worldwide, just like these coronaviruses are. So there's no reason to think that this will not show its head again come the winter season if it behaves like our seasonal coronaviruses. So I think time will tell. So as I mentioned, COVID-19 stands for Coronavirus Disease 2019, which is the name of the disease, and it's caused by severe respiratory syndrome coronavirus 2, or SARS-CoV-2. Very similar name to SARS-CoV-1, 2002, but it is not exactly the same virus. It's the same family. So don't confuse the two. Now, some of the epidemiology. You all are aware, you listen to the news, you've heard this for months now of numbers worldwide. And I will get into some of our local numbers, but there was a large study of early transmission of COVID-19. This was a study of the first 425 confirmed cases out of Wuhan, China. And I'm not going to go, there's a lot of detail on this. Don't read all the detail, just look at what I circled. First of all, this disease was discovered out of a seafood market in Wuhan, and then it took off. And it started in December, late December, associated with a seafood market. And eventually, a novel coronavirus was identified later on, probably, I think, in January, around January the 8th. And then the first confirmed case of China occurred about January the 13th. It may have come from an animal called a pangolin, which is an anteater. They're not sure. They think the original source may be from bats, but there are animal sources of these viruses and normal animal reservoirs. So right now, they're still doing a lot of research into where the virus originally comes from. And of course, it spread rapidly throughout the world, from China to Southeast Asia, and then around the world to Europe. Italy was hit harder than North America, as everyone has seen on the news. Now, if you look at the epidemic curve for the world, it's quite dramatic. This is just a few, I think this was just last week. It hasn't changed that much. But if you look at the small curve on the left, that's China. That's China's epidemic. And then the huge curve on the right, the bars, that's the world. And you can see that the Americas are the large yellow bars, the highest ones. Europe and some of the Mediterranean are the red bars. So you can see how it's really taken off, where the numbers are huge compared to the epidemic in China, which is pretty much a low level, but not petered out. China continues to teeter along with low levels of infection. If we look at numbers, it has infected worldwide about 3.5 million cases, and in Canada about over 60,000 cases now, with about 3,600 or more deaths so far, and about 279 cases, I think, in Northern Ontario. Ontario total cases have been about 18,000, and it looks like about the crude mortality rate, if you just look at the total numbers of patients that die over the total number of cases, it's about 7.4% overall. But this mortality does vary in different populations, and I'll talk about that in a bit. But it has really hit those over the age of 80, the elderly. Of those 1,361 deaths, 957 of them have been in people over the age of 80, and another 338 over the age of between 60 and 79. So the elderly are particularly hit hard, hence the major push to screen and take action in the elderly populations, particularly where there's large numbers of them together, like in long-term care, nursing homes, and retirement homes. So if we look at the epidemic in Ontario, here it is just as of a few days ago. I sort of follow it every day. You can see that it has gone up from March the 11th, sort of hit a peak around a month later, April 15th, and now we are about a month later again. This is about 2 months. 1 month going back, 1 month going forward from April 15th, and it will be interesting to see where these curves land up. Some bars are higher than others, and the numbers are delayed, but you can go on the public health information website every day and have a look at the curve, but it is coming down dramatically. Where it's going to land in the end is going to be interesting, and whether or not we're going to have another surge later is really an unknown. Testing and case definition. This has been especially case definition has been a thing that's been in evolution. This is the latest case definition as of, I think, I can't read the date on that because I can't see the slide completely. May the 11th from Public Health, and this has been an area that's been difficult to navigate, to tell you the truth, because of changing case definition slightly by the Ministry of Health. But currently, as it stands, this is the case definition for a probable case where you should suspect someone with COVID. And I'm going to go through this. It is anybody who has symptoms with COVID-19. And I'll go over what those symptoms are, because those symptoms are also a list that's in evolution. But you have to have symptoms and travel to an area that's been affected or outside of Canada in the last 14 days. And really now everywhere is affected. So that question is becoming more and more mute. Or close contact with a confirmed case, or lived in and worked in a facility knowing to experience an outbreak, like a long-term care home or prison, or a person with symptoms compatible with COVID-19, and there's some leeway there with the lab diagnosis. But really, it's an individual who has symptomatic and has some risks. And what are those? And a confirmed case, of course, is someone who's been swab positive. Nasopharyngeal swab is positive. That's pretty straightforward. But this is the definition based on the symptoms. And these symptoms are changing and being modified over time. It's been even a challenge for me to keep up with this with the Ministry of Health. But the major symptoms of COVID-19 are respiratory complaints, dyspnea, one or more symptoms of a sore throat. Actually, hoarse voice was just taken off. Difficulty swallowing, loss of taste or smell, chills, headache, fatigue, some abdominal pains, but also respiratory complaints on that as well. I had that on another slide. I didn't have that, but the respiratory complaints, dyspnea, cough, and shortness of breath are the major symptoms, okay? And there are atypical symptoms which can occur in the elderly. And this is going to be difficult to kind of navigate, because the elderly, of course, can present in various ways with atypical symptoms like increasing confusion and falling and functional decline, or if a patient has radiographic evidence of pneumonia. So for a probable case, these patients they have to be isolated, they have to be tested, and they're usually isolated either at home in self-isolation, or if they're admitted to the hospital, they need to be isolated, swabbed, and tested. In terms of testing, serology is not available for this disease. The CDC is working on serology for antibody testing. It does seem that patients, according to the literature, that patients usually will develop initially IgM antibodies and then IgG antibodies. And these do not start to develop until days or a week into the illness, and then will peak. The question remains and is outstanding is whether or not these antibodies are actually protective against reinfection. The experts probably think there is some protection from reinfection immediately from SARS-CoV-2, but whether there is long-term protection is unknown, because we do know that with usual endemic coronaviruses, seasonal coronaviruses, you can get reinfected year to year, like you can with influenza. So the antibody protectiveness seems to last for a while, but over months and certainly over a year seems to be lost, where you can get reinfected. And we don't know if this is the case with COVID-19 or not at this point. And serology will be important in doing surveillance in the public realm. But the major test is a nasopharyngeal swab with PCR testing. And if you look at various specimens, there was a study published in JAMA in March, looking at 205 patients in China with confirmed COVID. And they found that the specimens which were PCR positive most likely would be a BAL, like a bronchoalveolar lavage, but this is not done in the majority of patients because of risk. Sputums are positive about 72%. Nasopharyngeal swabs were positive in this cohort of patients in about 63%. Throat swabs 32%, all the way down to feces, 29%. It is unknown also whether or not, if the PCR test is positive in feces, whether this actually means infectivity or not. It does not necessarily translate into infectivity. This only translates into RNA test positivity. Blood in 1%, and urine, it's virtually not found at all. There's a COVID test requisition, which needs to be filled out with patients and sent in, listing symptoms and what kind of specimen is being submitted. So this is the test requisition that we have in the hospital, and it's available through the Public Health Ontario site with a nasopharyngeal swab or a throat specimen for testing. Now, what about the clinical course of the disease? There is more and more being learned about the clinical spectrum of this disease. This is a study out of China as well. And this is one of the largest clinical studies of about 72,000 cases from China. And what were the major findings here? Which patients were mostly affected in China? Well, first of all, majority of them were older patients, first of all. Very few children, really 1% under 10 years in this particular cohort of patients. And most had mild disease, 81% mild disease. And these results have been duplicated in multiple other areas of the world as well. Whether it's the European data or the North American data, it seems that about 80% of patients develop mild disease, about 14 or 15% develop severe disease requiring hospitalization, and about 5% end up critical in our ICUs. The overall case fatality rate in this 72,000 patient cohort was over 2.3%, but over the age of 80, it was almost 15%. And in those who are critically ill, was close to 50%. And in some studies, well over 50% if you're intubated and ventilated. There were other studies looking at clinical characteristics of coronavirus as well. In this study, this was one of the largest detailed clinical studies of over 1,000 patients in China in about 522 hospitals in 30 provinces. And once again here, the median age was around 47. There were more males than females. 5% were admitted to the ICU. In this particular cohort, 1.4% deaths, which I find very remarkable, actually, and I'm not quite too sure how true that result is, but most of them presented with fever, cough, some of them with diarrhea. The median incubation period was about 4 days, and in most studies, the mean incubation period in the majority of patients from the time of exposure to initial symptoms is about 4 or 5 days, but that can range. Chest x-ray abnormalities in almost 60%, coexisting disorders in about a quarter of them, and severe disease occurred in about 16% down at the bottom. This is how they present if you do develop severe disease. The patients that land up in the hospital can develop severe viral pneumonia bilaterally, and some of them develop ARDS and develop rapid respiratory failure needing intubation and ventilation and being put in the ICU. And they can develop bilateral diffuse pulmonary infiltrates in kind of a ground glass appearance. And these are CT scans of patients as well, showing various stages of disease in different patients, showing bilateral involvement on CAT scan. Now, the majority of our patients don't undergo CAT scanning. They have a chest x-ray only. We don't need to do a CAT scan. It's not necessary. But in some of the early studies, particularly in China, they were, of course, investigating this and doing CAT scans. What about the clinical course in those patients that are critically ill? This is a study out of China as well, published in The Lancet in February. This was a single-site retrospective observational study, which a lot of these studies are. This was over 700 patients who developed pneumonia. 51 became critically ill. And in this particular cohort, there were 61% deaths. So 32 of the 51 died by day 28. The median duration to death was about 7 days. So once you're intubated and ventilated in this cohort, patients died often around day 7 was the median time. ARDS in 67%. Some of them required ECMO and vasopressors in 18%. More males and the median age was 60. And this is the curve of the deaths, the survival curves, and you can see the probability went down over 7, 14, and 21 out to 28 days over time in these ICU patients, most of them intubated and ventilated. Now, what if you look at more local data? This is some of the information from New York. And of course, they have been hit very hard with COVID-19, as has Washington and has Italy and some other areas of Europe. But this is one study in New England Journal of 393 hospitalized patients. Once again, median age around 62. Obesity seemed to be a risk factor, more males than females, and about a third of them ended up ventilated. Particularly, risk factors would be males, obesity, and if they had liver test abnormalities, a CRP elevation and ferritin elevations. And these are some of the lab abnormalities which occurred in these patients with an overall mortality of about 10%. It actually isn't as high as I thought it would be in this particular cohort. Now, one interesting feature of this disease in terms of its clinical course is this thing called a cytokine storm. This is described in a article in the Lancet in March, and is what happens with this disease in a certain subset of patients is that they get a very hyper-inflammatory response to the virus. And it's a subgroup, and they're trying to define who this subgroup is. The other name given to this cytokine storm is secondary hemophagocytic lymphohistiocytosis. I have to read that to get it right. Long name. But it's really a hyperinflammatory syndrome with ongoing fever. They develop a drop in their blood counts, very high ferritin level. They develop pulmonary ARDS. They end up on a ventilator. Their mortality is very high, and they have very high interleukin-6 levels. And there are drugs that are targeting monoclonal antibodies, targeting interleukin-6, to be given to patients before they develop a cytokine storm to see if they can prevent them from going to the ICU. So there's ongoing clinical trials right now at drugs to prevent the cytokine storm. So the overall clinical course of this disease is, as I mentioned, on about day 0, when a patient is exposed, about 5 days later, if they become symptomatic, they develop a flu-like illness. And you have to remember that about 80% of these patients are managed at home, and they get over their disease in 1 to 2 weeks. Some have very, very mild disease. Some have moderate disease, but they're at home and they recover. But about 15% of these patients are admitted to hospital, and this seems to occur about 5 days later in the majority of patients. So they're grumbling along at home. They worsen and worsen. About 5 days later, they're admitted, and they're admitted with pneumonia and just doing unwell. And one interesting feature of this disease is that the degree of hypoxemia or hypoxia, their oxygen saturation, doesn't seem to match their degree of dyspnea or their chest X-ray abnormalities. So they seem to be more hypoxic than their clinical presentation seems to suggest, or their chest X-ray. So there's a discrepancy there, which is an interesting finding. But of these admitted patients, about 5% land up in the ICU. And that seems to happen after another 5 days in the hospital. So they're grumbling along in the hospital, and then they worsen and worsen and they crash. So of these, about 5% land up in the ICU, sometimes with ARDS, severe pneumonia, intubated, ventilated, with multi-organ failure. And they're finding more clinical features of this disease as time goes on in these critically ill patients. So this is the general clinical course of the disease. What are risk factors for complications? Well, I think it's becoming increasingly clear that those that are elderly over the age of 65, any individuals with chronic lung disease, cardiovascular disease, diabetes, obesity, any patients that are immunocompromised, such as those on high-dose steroids, HIV patients, transplant patients on immunosuppressive drugs, end-stage renal disease, and liver disease are at increased risk for complications and severe disease. There have been attempts made at trying to predict who will develop severe disease, who will progress. There's an H score to predict a cytokine storm, and I'm not going to go. What that means. Sorry. There's an H score, and there's also a call score to predict a disease progression based on comorbidities, age, lymphocyte count, and their LDH. So for instance, if you had a patient that comes in who has COPD or heart disease, who's admitted, and they're over the age of 60, and if their lymphocyte count's less than 1, and if their LDH is more than 500, they've got over a 50% risk of severe disease progressing, leaving them in the ICU. So this is a predictor of disease, and there's other predictors as well. Some of them more complicated and involved than others. Hold on here. Sorry. Here we go. Now there are new clinical features of COVID that are coming out. Some of them are neurological, but they're not sure if some of these neurological features are because of critical illness in the ICU, but there are neurological findings they're seeing in patients, particularly post COVID once they recover. Cardiovascular effects, and there's clearly now I think more and more evidence that this affects the heart. You can develop a myopericarditis, ST segment elevation in patients. And of course, patients that have cardiovascular disease are at more risk of progression. Loss of taste and smell is an interesting phenomenon, found more likely in mild patients, but can be the only presenting symptom of COVID. And they're not sure if this is a neurological pathology or an obstructive pathology. There's what they call COVID toes in children. I'll show you a picture, which is a rash on the feet, renal failure, hypercoagulable state. They're finding that patients that are critically ill are developing deep venous thrombosis and arterial thrombosis. They're not sure why. And they don't know if this is because of endothelial damage from the inflammatory response or the virus. But this raises the question in regards to anticoagulation of these patients, or being more astute to the fact that if they suddenly decline, are they developing deep venous thrombosis, pulmonary emboli, worsening their disease? So there's more and more reports of this coming out. A multi-system inflammatory vasculitis, mostly in children, is now being reported and has been added as of a few days ago to the Ministry of Health list of symptoms. Here are the toes. They're called COVID toes in children, and they seem to present with this odd rash on the toes, almost vasculitic or blistering. And there's reports of this mostly in children. And this is the multi-system inflammatory vasculitis that they've seen reported in children with COVID-19 as well. There's more and more reports of this, so just keep yourself aware of this as a possibility. Transmission, lots of work on transmission. This involves routes of transmission, viral shedding, asymptomatic patients, and pre-symptomatic patients. Now, with SARS-CoV-2 shedding, it seems that patients can shed the virus 2 days before their symptoms start. Their viral load is the highest at the beginning of symptoms, and their nasopharyngeal swab may remain positive in moderate cases for 7 to 12 days, severe cases 14 days, and in some patients up to 24 days, and even prolonged shedding after their symptoms have resolved. It can be found in the feces, especially in children, up to 5 weeks, but they're not sure if this PCR positivity in the feces translates into infectivity. There has not been a lot of reports of fecal oral transmission of this disease. It's mostly a respiratory disease by droplet spread. If you look at the nasopharyngeal to throat PCR positivity, the top bar here represents, this is a cohort, a bunch of patients, and they just looked at the nasopharyngeal swabs and throat swabs, testing of these patients consecutively over 21 days. And this is how the viral levels come down over this period of time. NP swabs are the top curve, throat swabs are the lower curve. So the NP swabs tend to be more positive than the throat swabs. I'm going to forget, I'm going to skip this. Okay, I'm going to go to some infection control. Yes.
Roger, I was wondering if I could jump in and ask a few questions, if that's okay.
Absolutely, yes, yes.
We have a few questions here. So one of the questions is, what is the false positive rate for COVID-19 testing?
Okay.
And then with the follow-up question of that, when or should we retest positive patients, especially those who are asymptomatic in long-term care facilities?
Okay, good questions. And there's been lot of debate around that. Unfortunately, we do not know the false negative rate of PCR testing, because we don't have a technical gold standard. Probably it's pretty low. It's thought, but we do not have a number for that, unfortunately. We do know that the majority of patients, by the time they develop symptoms, are PCR positive. And our testing that we have in the lab right now at HSN is, I was told, compared to the public health lab PCR testing in Toronto, because they have different reagents, ours is 98% sensitive, 96% specific, but we don't know the false negative rate. That does pose a problem with asymptomatic patients. Your second question was regarding retesting in asymptomatic patients?
Retesting asymptomatic patients, and this is specific to the long-term care facilities. So when should we retest these positive patients, or should we even retest these positive asymptomatic patients?
Okay, so these are COVID patients that are tested positive, correct?
Right.
The general rule of thumb for these, as far as I can tell from the Ministry of Health, is to retest them probably at about 14 days later after their initial test was positive, and they're going to have to be isolated as well. And you usually need 2 PCRs that are negative to consider someone resolved. Now those are the rules in hospitalized patients. I don't know the exact rule in long-term care, and whether public health has come out with different rules in long-term care than in the acute care facilities. But in the hospital, if we have a COVID patient that's positive, it's usually 14 days from the time they present, and they need 2 PCR tests that are negative to clear them of disease and consider them resolved and take them off isolation.
Okay. Thanks very much.
This ties into, yeah.
I was going to ask you one more question, if you have time.
Yep.
So this is another question. There's been significant evidence of infection, so a superimposed secondary bacterial pneumonia with COVID-positive patients. Is there any subsequent evidence for antibiotic prophylaxis in admitted ICU patients?
Well, our standard of care is to give antibiotics in these patients. They're given usually ceftriaxone and azithromycin because of the potential of other co-infections. But I believe most of the series have not shown huge amounts of co-infection with other pathogens, to tell you the truth. But I think the fear of that exists, and we have no treatment specifically for COVID-19. So the best we can offer is at least to cover them with prophylactic antibiotics empirically. Okay, is really the bottom line. Whether they're truly required or not, I think time will tell.
Yeah, and we have the prophylactic antibiotics on our PPOs for any patients with probable or confirmed COVID coming into the ICU right now.
We usually treat them for community-acquired pneumonia as well with azithromycin and ceftriaxone. But whether it's really required and whether it makes a difference, I don't know.
Okay. This is all really exciting. I don't want to interrupt your talk too much. I'm learning lots.
No problem. So infection control, of course, this is droplet transmitted. Wash your hands, don't touch your face, use surgical gowns, gloves, face shield, and goggles is the standard for a COVID patient. For aerosol generating medical procedures, which I'm not going to get into in detail, you need to use an N95 mask, negative pressure room, and droplet precautions, sort of like enhanced airborne precautions because of that potential of aerosolization, only for aerosol generating medical procedures though. How to avoid COVID: wash your hands, don't touch your face, wear a mask, and particularly when you're dealing with patients, when you have close contact with patients. So basically to use the proper PPE with COVID or probable COVID patients. And of course, we can always talk about masks out in public. That's another whole issue as well. And I can weigh in on that later if it comes up. In terms of management, mild patients, as I said, these are treated at home usually. Okay, public health has given us guidance about how long to isolate them for, usually for 14 days from their symptom onset, provided they become symptom-free. Outpatients do not usually need or require repeat PCR testing like in-house, like hospital patients. For inpatients, we usually do 2 PCR tests that are negative before taking them off isolation. At our hospital at HSN, and this may be different in Thunder Bay or other peripheral hospitals, we have an admission order set to help our emergency department and our hospitalists and those admitting patients to initially admit patients. These are not ICU orders, but basically I'm just going to highlight just a few things that are important on an admission algorithm for these patients. One of them is, of course, their diagnosis. How are they labeled? Are they a probable? Do they fulfill criteria or not? Or are they actually a confirmed case? Number 2, infection control precautions. To properly isolate these patients using droplet precautions or airborne precautions if you're doing aerosol generating medical procedures, which we're trying to avoid in most patients. The other item is oxygen therapy. These individuals, if they're getting worse, they need oxygen therapy, and to avoid certain types of oxygen therapy, which may be aerosol generating. So in our hospital, we've gotten rid of Venturi masks, Airvo, BiPAP, CPAP, on our COVID patients, and nebulized medications because of the risk of aerosolization. But you have to follow the oxygenation in these patients if they're on the ward in case they deteriorate. There's also an issue of proning these patients, changing their position on their side, for instance, various times. It seems to help with the oxygenation in the lungs, and this is even true on patients on the ward. And I know they do proning of patients in the ICU on a ventilator as well, and this seems to help patients. And then IV fluids. Generally, you want to keep these patients on the dry side, not the wet side. We usually do not order IV fluids on these patients if we really think they've got COVID or they're confirmed COVID. They usually have a saline lock and they just take oral fluids. So we're not pumping them with fluids. You don't want to have them wet. They need to be on the dry side. And then, of course, lab investigations and what is ordered. Obviously, a COVID-19 screen and other respiratory viruses during those seasons, and certain blood tests. And certain blood tests which help here, to give you a clue they may have COVID, is their white blood cell count. They're usually lymphopenic. Their lymphocytes drop. Their platelets drop. They may develop anemia. And they have a marked elevated ferritin, CRP, and D dimers. And the levels of these and how elevated they are seem to relate to their severity of their disease, or how risky they are for developing progression, as well as their LDH and liver transaminases. As I said, avoid aerosol generating medical procedures, and avoid usually systemic steroids. Watch out for myocarditis and pericarditis. Sorry, there. I don't know if I should go into this or not. I think I'm going to skip this. Let me skip this because for time. I could always come back to it. It involves when to take patients out of isolation. And I think we've talked about that a little bit already. Treatment. Now, there's lots of papers out on treatment. This is a whole topic all in of itself. I can't even keep up in the literature in terms of clinical trials. There are many trials of drug therapy, many trials of vaccinations. Treatment of COVID-19 falls into several categories. Antiviral drugs, which we'll talk about a little bit, anti-inflammatory drugs, convalescent serum, and vaccination. Antiviral drugs. I'm going to touch on just the major ones. Of course, chloroquine and hydroxychloroquine has gotten a lot of press release. It's an anti-malarial drug, but it does block viral entry, apparently, and it has some anti-inflammatory effect. But unfortunately, the clinical trials don't bear this out. There's no clear benefit right now for hydroxychloroquine and azithromycin, unless maybe you're in a clinical trial. Its effectiveness has not really been very impressive at all. But there are ongoing randomized trials underway, and there's a nice, this is a nice review of the treatment in JAMA in April of last month. So hydroxychloroquine really hasn't proven itself out, to tell you the truth, not yet. This is a study looking at the viral load in nasopharyngeal swabs out of France, which fueled a lot of interest in hydroxychloroquine. But here we're getting down to how well a study is designed. And design study and dropout rates and size is extremely important. This data is very, very impressive for only 20 patients. Look at the distance between these curves. On top, we have controls, and then we've got, these are patients who have COVID-19. Nasopharyngeal swabs in hydroxychloroquine in the blue curve, and hydroxychloroquine and azithromycin in the green curve over day 0, 1, 2, 3, 4, and 5. Look at the viral load drop between those curves. Is that good data? It looks impressive. It looks very impressive for only 20 patients. But this French study dropped out 6 of their hydroxychloroquine patients because of intolerance. 6 patients out of 20 is huge. And the numbers are very small. So you have to read the data extremely carefully. This researcher also has had questionable publications in the past, which have been pulled out of the scientific world. So that being said, be careful what you read, be careful what you look at, and look at good studies, okay? So this looks impressive, but it's not as impressive as the graph implies. Okay, lopinavir and ritonavir. This is an HIV drug that I've been using for years. It's called Kaletra. They thought this may work because it's a protease inhibitor. It doesn't work. The trials, I think that there was a study in the New England Journal of Medicine on March 18th. I got it listed at the bottom there, of the trial with lopinavir and ritonavir, a pretty good trial. And it really showed no effect on clinical course of the disease or mortality. So there's no benefit over standard of care with lopinavir, ritonavir. Remdesivir. Well, remdesivir is the drug, of course, Gilead's drug. It's an antiviral. This is the current study, the ACT-1 study, that they released preliminary data, I think 2 weeks ago. This is a large study of, 1,063 hospitalized patients, and they randomized them between remdesivir intravenously and placebo. And they're looking at a primary outcome in terms of clinical endpoint, in terms of improvement of their disease and mortality. They released early data, preliminary results, because they were somewhat impressive. And you can see the curves there. There was definite statistical significance between time to, I think it's that time to, faster time to recovery. Sorry, I can't read this because my little icon's in the way. Let me just move this out of the way. Sorry, primary endpoint, time to recovery, median number of days, 11 days with remdesivir, 15 days for placebo, with a very impressive p-value, but mortality did not reach statistical significance, though it was close, 0.059. 8% mortality with remdesivir, 11.6% with placebo. So it will be interesting to see what the final data and the final analysis of this data shows in the end. But they released this, I think, 2 weeks ago, and it does show some benefit of remdesivir. All right, and this is the same data. They also looked at remdesivir 5 days versus 10 days duration in another trial with Gilead, which is the pharma company which makes it, and there was no difference between the 5 and 10 day regimens. Other treatment, anti-inflammatory drugs like interleukin-6 monoclonal antibodies have promise in preventing that cytokine storm. Convalescent plasma is old treatment. Of course, you're collecting plasma. There is a trial in Canada collecting plasma from patients who have had COVID and administering that plasma to patients who are admitted to hospital. The early trials in China in small numbers actually looked impressive, with far fewer patients progressing to severe disease who received convalescent plasma. So this will be interesting to see if this helps. This is an old treatment. This goes back a long time, 50 to 100 years in treating various diseases, including the Spanish flu and diphtheria many, many decades ago. And there's, of course, vaccination. Vaccination, I don't have an awful lot to say on vaccination because it's a huge area all in of itself, and it's complicated. And I'm not a virologist or immunologist. But this being said, they hope there may be a vaccine within 12 to 18 months. But the thought is to have a vaccine in 12 to 18 months would mean skipping many of the steps of scientific scrutiny that you need with vaccination. You have to remember, most vaccines that have been developed have taken 20 years of development. 20 years of trials and going through all the ropes of safety and large clinical trials. And most of those vaccine trials have occurred in cohorts of between 20 and 50,000 people. So put that into perspective. If they hope to get a vaccine in 12 to 18 months, it's going to have to be extremely impressive. They're going to have to skip animal trials, animal studies, and go directly into humans. So I don't know if there's really going to be a vaccine soon, to tell you the truth. But I'm not a virologist, and I'm not directly involved in the field. But so far, there's no vaccine for the endemic coronaviruses, which have been existing for years. Areas of uncertainty. I'm going to sum up here. There are varying mortality rates around the world. Why this is a bit unclear. There's the whole question of asymptomatic carriers. There are patients that seem to carry the virus with no symptoms, and that number is probably larger than we realize. Mask use in public, does it work? I personally believe it does work if it's used properly in the right setting. If you're in a congested area and in an urban area where there's COVID, I think it can work. If you're walking your dog by yourself down the street, mask use will do you no benefit. Take the mask off. So it all depends how you're using it and when you're using it. I think it can make a difference within the public realm and within a country. Reinfections, it's not known whether we can become reinfected or not. The immunity is unclear, whether we are immune after having infection. Serology is being developed. Pregnancy. I think there was, Sarah, you said there was one question about breastfeeding and pregnancy. Were there any other questions regarding pregnancy? Not that I'm a pregnancy expert, but.
No, I've only had that one question, is what should be our advice as physicians to women who are breastfeeding?
Yeah. Well, in regards to pregnancy, there's not a lot of data that there's good vertical transmission of this disease, though there have been case reports of vertical transmission. Most of the studies have not shown virus in the placenta or in the amniotic fluid, and most studies have not really shown vertical transmission. Breastfeeding is considered to be safe. It's not in the breast milk, and they are suggesting, and Public Health Canada also recommends proper hand hygiene, mother wearing a mask with baby contact, skin-to-skin contact, and to continue breastfeeding. So breastfeeding, as far as we know right now, is not contraindicated. Okay. Treatment vaccination I talked about, and there's post-morbid morbidity as well. I'm just going to go through my case again. Going back to my case, my 73-year-old man. First of all, he's 73. He falls into a risk group. He's got hypertension and COPD, two other risks of comorbidity for severe disease. He presents with typical symptoms: fever, cough, shortness of breath. He's on losartan and inhaled glucocorticoids. The inhaled glucocorticoids are fine. The losartan is an ARB. ARBs and ACE inhibitors can be continued in patients who have COVID. Initially, we thought we should pull them back because of this ACE2 receptor, but that evidence has not really been borne out in the literature. They have found that they are safe and they should be continued if patients are already on them. So this patient is high risk for COVID-19 because of his age. He's got dyspnea. He's got comorbidities. You should refer him for a nasopharyngeal swab, to wear a mask en route to hospital if he's going to go there to be tested or admitted, with close monitoring. Continue the ARB. Upon discharge, remain isolated for 14 days after symptom onset. If he's still hospitalized at the time, he will require 2 negative nasopharyngeal swabs, usually at about day 14. So that's it. This gets back to my learning objectives. I can take questions, Sarah, if there's any.
Sure, I do have a question. Someone actually posed this question. I have the same question. So you quoted a study in China about the testing related to SARS-CoV-2. It was a JAMA paper published at the beginning of March, and it had the list of patients in China confirmed with COVID and the sensitivity. So the bowel had 93%, but the nasopharyngeal swab had 63% sensitivity. And so I am admittedly a bit confused. How do we interpret that our PCR swabs are 98% sensitive when some of the studies from China were showing less sensitivity? How do we interpret that literature and that data, knowing that there's constantly ebbs and flows there?
Yeah, good question. Some of the One of the major problems with the nasopharyngeal swab, I don't think, is the sensitivity of the testing and the PCR testing. It's partly the way the swab's taken and the inadequacy of a proper specimen, and not taking a nasopharyngeal swab correctly. So I don't know why it's only 63% there, and I don't know what their PCR testing was there in China in that particular study of 205 patients. So it's just interesting. Our tests are quite high. The sensitivity is quite high in detecting disease. I think it's developed since this China study. But the major reason for our false negative test, I think, is improper specimen collection as well of a nasopharyngeal swab. And maybe that's why the BAL.
I would agree with that. I've seen some very scary videos on social media of nasopharyngeal testing where I'm worried they're actually going to go into the cranium vault as opposed to acquiring a nasopharyngeal swab. So thanks for that.
Yeah.
The other question, there's another question, with our increasing awareness of asymptomatic or very mild illness, do you think that this is going to affect our estimation on case fatality rates? Because there's now more awareness that there's more asymptomatic spread than I think we thought originally at the beginning of March. And so do you think this is going to affect our overall mortality? Because right now you quoted a 7.4% mortality rate in Ontario. But have we really captured all the asymptomatic cases in Ontario? I don't think so. And so would that actually affect our fatality rate for COVID-19?
It will affect crude mortality rates because of the change of the denominator. And as we realize the asymptomatic patients affected, we may find that the population gets COVID-19. That would dramatically reduce the true crude mortality rate of this disease. But unfortunately, we don't know because we are not doing nasopharyngeal swab the whole population. When we have serology and antibody testing, and we're able to go back and actually test a population, we're going to have a better idea of the epidemiology and the true mortality rate of the disease. So it's an unknown, the true mortality rate.
And that's been one of the really very much tremendous challenges of COVID-19 is the unknown and the constant evolving literature that changes. And I'm glad we're in a space where it doesn't seem to be changing hour by hour, whereas in mid-March it seemed all the evidence was changing so quickly. We do have a question of whether or not you think that the COVID virus has the potential to mutate and whether or not there'd be clinical implications to this.
Sorry, Sarah, you're really brilliant. Your question actually.
Oh, so sorry about that. It was a question of whether or not you think the COVID virus has the potential to mutate.
Oh, mutate. There is some data out there. I don't know if I can speak on that, to tell you the truth. I don't think I'm not up to on the science of the change of the virus or the mutation. So I don't really want to dare say. I haven't read an awful lot of information about drastic mutations in the virus. I haven't seen a lot of publications on it. There may be some, but I can't really say. I'm not really up to date enough on that to comment, I don't think.
Okay, fair enough. Well, we're just coming up to 1:30 in the afternoon here, so that would be coming to the end of our rounds. I'd like to thank you so much, Dr. Sandre, for your time. That was an excellent and very detailed presentation about COVID-19. I was hoping that perhaps you can put on some of the resources or links to resources. We'll make those available on our CEPD website as well. And if there are any further questions, you can reach out to our CEPD office, and I'm happy to pass those questions along to Dr. Sandre as well, if you don't mind answering some more questions for our faculty. There's a link that Sarah Bazinet just posted to complete an evaluation of our Friday, May 15th COVID-19 rounds. I'd really appreciate if you could fill out those evaluations. We can only get better and stronger together. And the more feedback you give us, the more feedback we have to improve these rounds for you. So again, Dr. Sandre, thank you so much. I'll turn it over to James if you have any concluding statements.
Thanks so much, Sarah. Thank you, Roger. As Sarah mentioned, the evaluation link is on the site that you used when you came in. The other thing that we would like to tell you about is for you to join us next week. And next week, we're going to have 3 different physicians presenting. And what they'll be presenting on is optimizing effective virtual clinical care. We've all moved to a lot of virtual clinical care in all of our roles, and we've got a team that includes, it's going to be the A team next week. Andrew Pierce is a radio oncology therapist in Sudbury. Adam Moore is a family physician in Dryden, and Andrew Kucharczyk is a family physician in Sudbury. So please join us next week. As mentioned, the evaluation link is on the COVID site. And finally, another opportunity for learning some palliative care rounds on Tuesday, which will feature a speaker familiar with a COVID outbreak in one of our personal care homes. Thanks so much, Roger. Thanks so much, Sarah. Thank you, everyone, for joining us. We'll see you next week, Friday, at 12:30 Eastern Standard Time for a return of COVID-19 clinical rounds. Have a great day, everyone.
Thanks, everyone. Stay safe.